Je déclare ouverte cette réunion. Bienvenue à la réunion 53 du comité permanent de la Chambre des communes sur la santé. Nous nous réunissons pour 2 heures. Nous entendons des témoins sur l'étude de la santé des enfants. Oh,
Mr. Joe. Garon, est-ce que
Mr. Garon, can we test the interpretation?
Monsieur Johari, est-ce que la traduction fonctionne?
Does the interpretation work?
All right, we'll start again. I call the meeting to order. Welcome to meeting number 53 of the House of Commons Standing Committee on Health. Today we will meet for 2 hours with witnesses on our study of children's health. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. A couple of comments for the benefit of our witnesses today. For those who are participating on Zoom, you have interpretation available to you, and we know now that it is working. You have the choice at the bottom of your screen of either floor, English, or French. For those of you in the room, of course, you can select the desired channel. Please don't take screenshots or photos of your screen. These proceedings will be made available on the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. I would now like to welcome the witnesses who are with us this afternoon. We have Dr. Tracy Afifi, a professor at the University of Manitoba, appearing by video conference from the Canadian Counselling and Psychotherapy Association, Ms. Carrie Foster, President-elect, and Lindsay Thompson, the Director of Public Affairs, and from the Offord Centre for Child Studies, Dr. Stelios Georgiadis. Dr. Stelios Georgiadis. I hope that is a reasonable pronunciation. That's about the best I can do with the phonetic spelling that I've been provided. Dr. Georgiadis is the director and the McMaster Children's Hospital Chair in Autism and Neurodevelopment, and he's with us by video conference. Thanks to all the witnesses for being with us today. Each of you has up to 5 minutes for your opening statement, and we're going to begin with Dr. Afifi. Welcome to the committee. You now have the floor.
Thank you. The most recent UNICEF data on child well-being in high-income countries indicates that Canada ranks 30 out of 38 countries. This, along with our need to support children and youth to recover from the COVID-19 pandemic, emphasizes that now is when we need to fully invest in children and youth to foster healthy development and resilience. This requires several strategies. First, it's recommended that we need to invest in long-term funding for youth and child health research. Second, it's recommended that we need to implement strategies to effectively translate this research into policy and practice. Third, it's recommended that we need to train and retain healthcare and social service professionals to develop a network in which systems can share information and collaborate. And fourth, we need to be able to connect all children in a timely manner to healthcare and social services when needed. However, we need to consider these recommendations within the context of children's environments in which they live, grow, develop, and learn. What does this mean? It means for optimal health, we first need to ensure that children and youth's environments are both safe and stable. It requires an approach that requires addressing poverty, racism, and violence. Today, I'd like to focus on violence and the home environment to demonstrate that healthy child development is actually not possible when children live in unsafe and unstable homes. The Centers for Disease Control and Prevention in the United States indicates that safe and stable nurturing relationships and environments are important for preventing child abuse, neglect, and fostering resilience. But you might wonder, why do we need to prevent violence to improve health? The answer is that spanking and child maltreatment are associated with an increased likelihood of mental disorders, physical health conditions, and many other poor outcomes. An individual cannot achieve optimal health if they experience violence. So how common is violence in homes in Canada? Although we don't have representative data on spanking in Canada, we do know from community samples that hitting children as a means of physical discipline is common. We also know that there's conclusive evidence across decades and over thousands of studies that indicate that spanking is related to mental disorders, physical health problems, substance use disorders, and thinking about and attempting suicide in childhood and across the lifespan. Children who are spanked are more likely to experience severe physical abuse, sexual abuse, emotional abuse, and exposure to intimate partner violence. Our team has analyzed data from a nationally representative sample of Canadian adults who retrospectively reported on their childhood experiences. We found that 32% of individuals in Canada have experienced child abuse, including physical abuse, sexual abuse, and exposure to intimate partner violence. Let me repeat that. 1 in 3 Canadian adults have reported experienced child abuse. We further analyzed these data and found that individuals who experience child abuse were more likely to have depression, bipolar disorder, generalized anxiety disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, phobia, attention deficit disorder, eating disorders, alcohol abuse and dependence, drug abuse dependence, suicidal ideation, and suicide attempts. Our research has also indicated that spanking, slapping, harsh physical punishment, child abuse, and neglect are associated with increased likelihood of several physical health conditions, including hypertension, liver disease, diabetes, cardiovascular disease, gastrointestinal disease, obesity, and arthritis. So please recall the 4 recommendations I began with. All of these recommendations should incorporate violence prevention to achieve our greatest likelihood of improving health outcomes for children and youth. To summarize, recommendation number 1, long-term funding for research. We need ongoing data collection and infrastructure in place to be able to act quickly when evidence is needed, such as the COVID-19 pandemic. We did not have these research mechanisms in place during the pandemic, and we were not able to act quickly to produce data to improve the health outcomes for children and youth. What is needed is ongoing longitudinal, nationally representative data collection that includes measures of health, violence, other social determinants of health, systemic barriers, access to care, and potential protective factors. Recommendation 2, knowledge translation and mobilization to connect research and policy to practice related to improving health and preventing violence. Recommendation 3, training and retaining. We need to train and retain healthcare and social service professionals and develop a network in which these systems can share information and collaborate. Recommendation number 4, timely access to healthcare and child protection for all children and youth when needed. To conclude, violence protection and early health intervention will yield the best outcomes for children, youth, and families in Canada. Thank you.
Thank you very much, Dr. Afifi. Next, we're going to go to the Canadian Counselling and Psychotherapy Association. And will it be Ms. Foster or Ms. Thompson? All right. Do you have the floor for the next 5 minutes? Welcome.
Good morning. Bonjour. I'm here in the capacity of President-elect for the Canadian Counselling and Psychotherapy Association, the CCPA. I represent more than 12,000 members that provide essential mental health services across Canada. I would like to speak today about the significant mental health trends affecting children and how the government can take immediate action to relieve some of the burden to Canadians on the cost of mental health care. Children in Canada are desperate for and yet struggling to access mental health support. There is clear and growing need for help, but our system is failing these children. There is long wait times that demonstrate how the demand for services outweighs the capacity of providers. Les thérapeutes en
Therapists, counselors, and psychotherapists cannot meet the demand, but they are ready to do so. They are healthcare professionals in mental health services, and very available, as has been shown during the period of the pandemic.
Mental health care supports by increasing accessibility to providers is essential to pandemic recovery and to thriving and healthy society. Despite healthcare being a provincially regulated matter, there are small and actionable yet impactful federal policies and legislation that can be amended in order to improve supply and access to qualified mental health care providers in Canada. Mr. Chair, At present, counseling therapists and psychotherapists are the only regulated mental health service providers that must remit tax on their services. Physicians, psychiatrists, registered nurses, registered psychiatric nurses, psychologists, occupational therapists, and social workers are all exempt from GST, HST on their psychotherapy services. Les thérapeutes en
Counseling therapists and psychotherapists are excluded from this exemption. This situation contributes to reducing access to mental health services for children, and this by creating unnecessary financial pressure.
Counseling therapy, psychotherapy meets the threshold for tax exemption in the Excise Tax Act as it is regulated in 5 provinces. However, because the profession does not regulate the same title in all 5 provinces, title being a provincial decision, the Finance Department, the Department of Finance if you prefer, does not accept the counseling therapists and psychotherapists are the same profession. In order to meet that minimum threshold, the profession is the same in all but name. Counseling therapists and psychotherapists across Canada share common scope of practice, abide by similar codes of ethics and standards of practice, have a comparable training and education profile, and a commitment and obligation to ongoing continuing education. They are qualified, competent, and available to meet the skyrocketing mental health care needs of children in Canada, yet the additional cost of GST and HST tax on their services is limiting their capacity to serve their communities and those seeking care.
To ensure universal access to all mental health professionals, the services offered by therapists and psychotherapists should be tax-free.
Would enable a child seeking care to access a few additional sessions over the span of a year. These extra sessions can make the difference between a child's ability to fully integrate their learnings and positive changes and habits for improved well-being. We call on the committee to support CCPA's recommendation to the federal government to legislatively amend the Excise Tax Act through a financial bill that adds the profession of counseling therapy and psychotherapy to the list of GST, HST exempt healthcare professionals. Merci beaucoup.
Thank you very much. I'll be happy to take your questions in English or French.
Thank you.
Thank you very much, Ms. Foster. And finally, Dr. Georgiadis, Dr. Georgiadis from the Offord Center for Child Studies. Welcome, Dr. Georgiadis. You have the floor.
Thank you, Honorable Chair, honorable members of this committee. Today I join you for the authentic and resilient city of Hamilton and the surrounding areas in the province of Ontario. I am here to represent the members of the Offord Center for Child Studies, which is a multidisciplinary research institute dedicated to improving the lives, health, and development of children and youth. The Offord Center is affiliated with McMaster University, McMaster Children's Hospital, and Hamilton Health Sciences. Today, I will position my testimony within one strategy for child and youth health that enhances all other strategies that are related to that. The late Dr. Dan Offord, founder of the Offord Center for Child Studies, believed that tracking children's life trajectories was vital to improving their health and well-being. To Dr. Offord, a clinician and researcher who worked at McMaster University, the birthplace of evidence-based medicine, data were the key. Data help identify and understand problems. Data lead to evidence that helps formulate, deliver, evaluate, and refine solutions. Our recommendations to the Standing Committee on Health, the study on children's health, reflect the belief that everything we do to improve, support, and sustain the physical and mental health of Canada's children and youth can become more efficient, effective, equitable, and sustainable through evidence that builds on high-quality research and data. The recommendations in this brief are a single overarching recommendation in 5 parts. A strong national commitment to research in child and youth mental and physical health needs to build on an infrastructure capable of supporting that commitment. And I'm glad that this recommendation overlaps with the one noted by Dr. Afifi earlier today. This is the best strategic path to achieving a significant and sustainable impact on all aspects of child and youth health. That impact can be pervasive, enhancing programs and services at the federal, provincial, territorial, and municipal level, as well as with not-for-profit institutions nationwide. A single strategic decision can generate multifaceted and lasting benefits for our children and youth. I'm now going to outline 5 high-level recommendations. Number 1, establish long-term funding for research on child and youth mental and physical health as part of a national child and youth comprehensive health strategy. Number 2, establish a national research network to collect, coordinate, and harmonize data related to child and youth mental and physical health in a research accessible system. Number 3, invest in training researchers and frontline staff who can conduct research, translate research into policy and practice, and deliver care that reflects and contributes to research. Number 4, adapt our existing data gathering practices to accommodate the specific needs of children and youth. And number 5, develop a learning health system in child and youth health to better connect research findings and evidence with the design and deployment of policy, care, and training. To conclude, currently we have inadequate information on a spectrum of health outcomes and factors, ranging from child and youth mental health to race, ethnicity, child maltreatment, and parental health. And many of the witnesses who have testified before this committee have shared this. Canada needs to invest in the coordinated effort and infrastructure required to generate the essential data, research, and evidence that will lead to evidence-based policies and practices that foster healthier children and youth, a healthier society, and reduced inequities. This kind of national investment, one that coordinates data gathering and analysis across provinces and territories, is a mandate that fits only with the government of Canada. And this is very timely within the larger context of the dialogue that's happening right now in our country with relation to health. As a nation, we need to expand and enrich our ability to coordinate data collection, management, and analysis. Then we need to embrace evidence-informed policy and practice to bridge the gap between research and the design and delivery of policy and practice that can improve the lives of children and youth and their families in this country. I want to end by thanking all of you for your time, commitment, and all you do for Canada's children and youth.
Thank you very much, Dr. Georgiadis. We're going to begin now with rounds of questions, starting with the Conservatives. Dr. Ellis, please, for 6 minutes.
Monsieur le Président, je voudrais prendre...
Mr. Chair, I would like to take a little time from this committee to acknowledge the tragedy that unfolded yesterday in Laval. This committee is very interested in studying issues related to children.
Je suis d'accord. Voulez-vous prendre...
And I do agree. Shall we entertain a minute of silence? Do you all agree with 1 minute of silence in memory of the victims of this terrible tragedy in Laval?
Merci.
Thank you, dear colleagues. Dr. Ellis, you have the floor.
Mr. Chair, and thank you, colleagues, for that moment to reflect. I certainly think it's germane given the difficult topics that we're talking about here and continue to discuss in Health Committee. If I might, Chair, I would like to start with you, Ms. Foster, talking specifically about the removal of GST and HST with respect to the services of counselors and psychotherapists. Could you just give us a brief idea of how that may affect accessibility and also how it may affect a practice? You know, some people may say, well, you know, it's in my province, it's 15% extra. Some people may not find that difficult. I guess perhaps in my mind the argument is, well, sometimes the people that need the help the most are those who are suffering the most financially as well. So if you could provide some comments on that, I'd appreciate it. Thank you.
Yeah, I think in this day and age, every penny counts with the increasing cost of food, with all that, and I think 15% in my province, which is Quebec as well, it will make a difference. I have clients all the time phoning that are asking for that. It's one piece of a larger picture that still needs to be looked at in terms of accessibility to mental health care for all Canadians on an equal basis. 15% for some is a lot. So I would suggest that it's an important piece. It's a piece that would allow at least perhaps those that can't afford 15%, which to you means perhaps less than it would to the clients I work with. I work with victims of violence. I also work with Indigenous folks. I work for the NIHB program, federal program for Indigenous and Inuit folks, and that makes a huge difference to them. So I think it's one piece, an easy ask, and allows those that can't afford it more access to. Thank you. Yes.
Thank you for that. And through you, Chair, if I might, can you talk a bit about the coverage for services? As we know, many different services of healthcare providers have coverage through the public system, and obviously through some people who are fortunate enough to have private insurance plans, there's coverage. Can you talk a bit about the membership of your organization and what percentage perhaps of your clients that you see may have coverage through other programs?
I couldn't give you the exact number but I know that counselors and psychotherapists nationally, and it differs from province to province, aren't necessarily all put on par with the insurance companies that are out there. So the Association of Insurance Companies is somebody that is an association we are working with to try and, get them to include psychotherapists as much as they include psychologists and social workers. So our membership are Indigenous folks, they're creative arts therapists, there's those that work in social justice contexts and in schools. Not all of them will be having access to counseling. That's a huge piece. That's a huge ask. We're not even asking for that today. But that is a big piece that needs to be looked at, in my humble opinion, as to how people can access. Yes, there is some availability. Not all counseling therapists and psychotherapists are admitted into all the programs. We are, at this point, we have been removed from the NIHB program, but added during the pandemic, and presumably when and if the pandemic ends, will be taken out again. So that means Indigenous folks that work with us that have their Canadian certified counseling permit will not be allowed to work in their communities with their people because they're CCCs. So I think it's really important that we kind of look at what that is so that we have not just early access to mental health, but also, Laval, that gentleman, perhaps if he had had help earlier on and had access to services, he wouldn't have been doing what he was doing.
Understood.
Perhaps.
Thank you. And
Thank you.
Once again, through you, Chair, if I might, in my mind, certainly we have a mental health crisis in this country. Perhaps a third of people suffering with difficulties with their mental health. How impactful do you think it would be if the Liberal government of the day actually transferred the $4.5 billion promised in the Canada Mental Health Transfer? How transformative could that be to the delivery of mental health care services and obviously to the mental health of Canadians?
So I'm not a financial expert, and I wouldn't think that that would be my place to answer that question. All I would say is that I think those parties involved in getting access for kids, access to mental health, and youth access to mental health is the important part. I will let you guys work that out, how you do it. Did you have anything to add to that, Lindsay?
Can you repeat the question, please?
Absolutely, I'd love to. Certainly we understand in Canada there's a significant mental health crisis, and with almost a third of Canadians suffering with their mental health. We know that the Liberal government has continued to promise a $4.5 billion Canada mental health transfer, which has not been actioned. And I guess in my mind, that type of money could be transformative not only to delivery of services, but obviously to the lives of the many Canadians who are suffering. And I wonder if you had a comment on how that may affect delivery of services in the lives of the people that you serve.
Absolutely, I can add to that. I think that the impact that it can have is beyond what we can possibly imagine. Some of the biggest issues that we're seeing is wait times. We know depending on if we're urban versus if we're rural, we can be waiting for children's services up to 2.5 years. Not to be dramatic, but this can literally be a life and death situation. We're seeing the number of mental health struggles amongst children has increased exorbitantly due to the pandemic and lockdown and isolation, all that causes, as we are, very social beings. And so with that, it could help to increase standardization of service across the system. We know right now there are some things that different governments are doing. For example, in Ontario, there's the structured psychotherapy program, which provides short-term psychotherapy, CBT specifically. That's an amazing program, but let's see how we can actually bolster that and fill in the gaps. And so for me, this is absolutely a great idea. It's a starting point to help increase standardization of access to different services, but also ensuring that we're not only providing certain types of therapies, right? Being able to give people the choice that they want. Just because a particular therapist is available doesn't mean that they're going to jive with that client, right? Therapy is all about that human connection, that relational connection, right? It's very different than what we might experience with going to see a physician who does, a diagnosis of physical symptoms, right? So we want to make sure it's not just about, okay, this person is in front of you, figure it out, but giving them options to determine what's best for their needs, whether that's cognitive behavior therapy, arts therapy, sand therapy, whatever that might be.
Thank you, Ms. Thompson. Next, Mr. Joe Harry, please, for 6 minutes.
Thank you, Mr. Chair. And right away, I want to acknowledge my colleagues' early intervention about the event that happened yesterday. Thank him, and also thank you for the moment of silence. Welcome all the witnesses today. Very, very important topic, and naturally very important to me as a founder of All Parliamentary Mental Health Caucus. I am invested in this very much. I'm going to start with Mrs. Foster. In your opening remark, you talked about the demand outweighs the capacity. And naturally, if we look at the study that we're doing, the demand that we're focusing on is the children, especially the children at the early stages. And the capacity this is where I want to focus. And often when I talk to different professional service providers, especially on the mental health and mental wellness, what they're talking about, if we look at the capacity in a much broader sense, rather than just the psychotherapist or the counseling therapist, then and include early intervention at early stages, then we may not be as bad as the situation that we are in. I'd like to know your point of view on that.
So I think the earlier we can intervene going down the road, the less, if because I'm a couple and family therapist, so I work with kids, I work with families, and if I can intervene when they're 4, 5, and 6, and I have clients that have had trauma at that age, as Laval kids will have at this point, if we can intervene now, then perhaps when they're 12, when they're 20, when they're 40, when they're 50, they won't need those many services. So the earlier we get to it, the less chance of children or young adults reaching a crisis level of need for therapy and not being able once again to service it. So hopefully long-term picture, we reduce the number of sessions required per capita if you want, right?
Mrs. Thompson, you talked about bringing other practitioner. You talked about the cognitive behavior therapist. You talked about art therapists. Those I also consider as part of the capacity that demands fall into. Can you give us your point of view on looking at the capacity in a much broader sense, rather than just the psychotherapist or just the psychologist?
Absolutely. So I will share that I myself am also a registered psychotherapist that's been in practice for many years. And so I think we need to get a little bit more creative in terms of how we look at psychotherapy practice. A big part of that, of course, is education to the public in terms of the different therapeutic modalities that are offered. From the research that I've done, there's over 200 different types of therapy that we can have available. And that is so important to what's available for Canadians because, so for myself as example, I provide cognitive behavior therapy. Carrie works with children, right? So it's going to be a little bit of a different angle. And it's all about what works for your individual personality. I'm quite type A, and so CBT works for me and for the clients that I work with, right? Some other individuals might prefer to work with I'm trying to give an example, a narrative therapy or internal family systems. And I'm happy to provide definitions of what all these different therapies mean, because there are many. But when we offer up the scope of the different types of therapy that are provided, we're giving more access to Canadians at whatever stage that they're at, right? Whether they're struggling with substance use, whether they're dealing with, they're survivors of domestic violence, whether they've gone through traumatic events, right? There's so many different types of therapies that research demonstrates that matches that particular and unique need. Another thing that I'd like to add to Carrie's point from earlier was that if we focus on early intervention and preventative care, that's going to have a huge ripple effect on the cost to the government in the long run. Not just the government, but also looking at a workforce in terms of absenteeism, the effects on families, how they're able to give back to the economy, right, and be able to participate in Canadian life.
Yeah, thank you. So I'm going to go to the partisan part of the the question period. My colleague, Dr. Alice, asked how impactful that $4.5 billion could be. Indeed, it's impactful, but having money thrown out without having accountability and transparency and measures of where it's been spent, it's been a challenge. As you know, in 2017, our government spent $5 billion on transfer to provinces on mental health, and you testified that you haven't seen any improvement on the access, you haven't seen improvement on increasing the capacity in dealing with that. So I'd like to know your point of view around welcoming the 4.5 as we agreed, but also what type of measures you really like to see that support that transparency and accountability, and most importantly, access for our children.
So in terms of measures, definitely having some kind of structure in place, some standardization and a set level of criteria of, who is this access being made available, or who is the money being made available to, making sure that a certain percentage of the funds are being earmarked directly for community services and agencies, being able to support those who need it most, who don't have, the extra 15% on top of the session fee to be able to afford more sessions. So for me, it's really about having structure and oversight, but also having flexibility, because the need province by province is very different, right? Ottawa Urban Centre, very different from rural Manitoba, very different from the state of affairs in BC, with the opioid crisis, right? So we really have to make sure that there's structure, but also flexibility, so have a good flow with it.
Thank you.
Thank you, Ms. Thompson. Mr. Johari, ensuite, Monsieur Garon pour
Mr. Garon, 6 minutes. Thank you very much, Chair. Clearly, I would like to join with my colleagues and offer my condolences, all my thoughts to the Laval community, to parents, to loved ones, and it's a good reminder that our children are so important. We have to think of them and we have to care for them. I have a question for you, Ms. Thompson. I would like to follow up on my colleague's question, a partisan issue, but it's an important question. In Quebec, are there standards, any rules to, are there provincial standards to measure? Personally, I don't know. I would have to do the research, and I would have to send you any answers in writing. Could you repeat that? Are there any standards on the services that should be provided to children? Is this an area where the provincial government sets standards? Yes. Since 2012, psychotherapy in Quebec was regulated. That's very different from the rest of the Canadian provinces. It's regulated by profession. I'm a member of the Order of Social Workers and therapists for couples and families. Well, the question is, are there government objectives for services for children? Are there governmental objectives? We'll have to look into that. It would be interesting if you could come back to us with any data. I've noted that for a number of years, people come to Ottawa and ask for money for transfers. They want federal money in areas that are provincial jurisdiction. It's true for education, health, and many different fields. It's as if we're in we've got the custom now of coming to Ottawa for transfers because the money is here, and then we ask for transfers with policies, and then we would have to measure and there would be accountability standards. Would you not think it'd be simpler that money just go directly to Quebec and then people go straight to Quebec and say, this is what we need and this is how we'll measure it? Do you not think there's something unhealthy about this? Well, that's a good question. Well, I always pose good questions. In my opinion, here, we're just part of Canada. So we're asking the federal government because the Canadian federal government is responsible. And if we could resolve this issue, it would be better for all counselors and all psychotherapists across the country. So to send the money to the provinces would resolve the problems. That's music to my ears. Now, a question for Professor Afifi. I've studied your research in recent days, and you have done a lot of work on traumatic events for children. Now, I'm interested in knowing, in your opinion, everything that unfolded during the pandemic, the lack of socialization, the school closures, delays in education, could this have a long-term effect on children? And what will be the impacts on the provincial healthcare systems?
Yes, thank you for the question. We do know with the data that's been collected so far that the pandemic is definitely having an impact on children. Currently, it's shown in mostly in mental health, but also there can be physical health problems as well. We have children who are born during the pandemic who haven't been adequately socialized, who have delays in speech, and we have a lot of increased anxiety and depression throughout that. So early intervention is necessary, absolutely. Could it be ongoing and have an impact?
Sorry, I didn't get any interpretation.
Hold for
C'est reparti, Monsieur le Président.
It's been fixed. Thank you. Go ahead.
Should I start again?
Non, vous pouvez continuer.
No, you can continue.
So in terms of will there be long-term impact, I would anticipate absolutely there's going to be long-term impact. But again, what we need to understand and know how to respond to that is data. So we need to be able to be doing research. We need to be able to providing evidence-based treatments for individuals, because if we don't intervene now when they're young, it has the potential for mental health problems to continue across the lifespan and become worse. And with that, we need to make it accessible to all children in a timely manner. So we need to be making
si vous me permettez,
If you'll allow me, a very precise question. There is a lack of data, longitudinal data, data collected by Statistics Canada. You've established that. Could you give me an example on a research question that you cannot answer today regarding children's mental health because of the pandemic, and that we don't have data for, data collected by Statistics Canada? Concrete example, please.
A concrete example is because we don't have good data before the pandemic, it's hard to ask and answer questions whether or not the mental health of children have changed due to or after the pandemic. If we had long-term data collection in place, we could simply ask the questions of whether or not depression, anxiety increased, and we can measure it precisely with data if we had baseline data to compare it to. We don't have those data structures and infrastructures in place for children and mental health. And with that, we don't have a lot of measures of other things that are important that are related to mental health, such as poverty, racism, violence. All of that was also increased due to the pandemic, and the pandemic influenced different people in different ways. And so if we had data in place before the pandemic, then we could easily compare to see if things decreased. Without the before data, we can just say, what is it now? And can we say, did it change? We can say that this is what it is now if we collect the data now, but we don't have the ability to compare differences.
Thank you, Dr. Afifi. Next, Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here. I'd like to add my voice to that of my colleagues on behalf of the New Democratic Party to express our deep sorrow and grief over the recent events in Laval, and our hearts go out to the parents and families and all those affected by that unbelievable tragedy. I'm going to start, Dr. Afifi, with you. How solid is the connection between corporal punishment or hitting children as a form of punishment and subsequent mental health issues?
The evidence is 100% certain that if you hit a child, you're increasing the likelihood that they will have poor outcomes, and that includes mental health, physical health. It also includes across the other domains of development, education, justice, etc. So does that mean every child who's hit will have these outcomes? No. Some children will be more resilient, and we're learning about why that's the case. But with 100% certainty, there's no question with the decades of data and thousands of studies that if a child is hit, spanked, slapped, whatever word we use, you're increasing the likelihood of poor outcomes for that child. That child will less likely to reach their full potential, less likely to be in optimal health. So that's 100% certainty. And importantly, there's no studies, not one study, that shows that hitting a child is beneficial to the child.
Funny enough, the Criminal Code of Canada actually authorizes parents, teachers, and other guardians to use physical force or discipline to punish a child under their care. It is subject to a test of what's reasonable under the circumstances. I'm wondering, domestic violence, by definition, violence in the home, is self-evidently harmful with respect to partners. Why does it seem to be a persistent issue to apply that same approach when it comes to corporal punishment of children in the domestic situation?
Yeah, it's a problem that we have in Canada, that we haven't repealed Section 43 of the Criminal Code. It's the only people that we're allowed to hit in our country by law is our children, and they're the most vulnerable and the ones that we need to protect arguably the most. But we're still allowed to hit them, and we need to repeal Section 43 so that we can, for the important reason of not making it criminal, not putting parents in jail. That's not the reason, and that's not what's happened in over 60 other countries in the world. We're behind on this. This first happened in 1970. Sorry.
To have a bill in Parliament to repeal that very section.
Yes.
To the Canadian Counselling and Psychotherapy Association, if you know, what portion of overall health care spending is currently allocated to children's mental health services in Canada? And maybe can you give us a general idea of how we compare to similar jurisdictions in the world?
That is a very good question. that I did not prepare for today,
Okay.
so I will get back to you
Thank
in
you.
writing.
According to CIHI, more than 1/4 of children and youth hospitalized for mental health conditions lived in the least affluent neighborhoods in 2020. I'm wondering if there's a link between poverty and mental health, poor mental health among children and youth.
In the research that I've read over the years, yes, definitely immigrant populations, racially diverse, any of the cultures that aren't necessarily high economic standard have an increased, poor neighborhoods tend to increase that.
Okay. Again, according to CIHI, rates of mood and anxiety medication use by children and youth were twice as high for females than males in 2020. I wonder if you can tell us a little bit more about perhaps some gender differences in mental health among children.
It's interesting because also statistically, when they reach adolescence, boys are more likely, especially in Quebec, to have a higher rate of suicide. So I think it's just perhaps, you know, how we socialize our girls and how we socialize our boys. The boys to be strong and the girls to, so there's a higher availability of sensitivity perhaps that we find. So that's how we socialize. Maybe that's work that I certainly do in my practice in terms of self-esteem here in other countries I've worked in. So, yeah.
We've talked a lot about upstream interventions. I think it's self-evident. I think probably everybody in this committee would understand and agree with that. Can you give us an example of a concrete, sort of pragmatic, practical upstream intervention that you would recommend the federal government sort of champion to start actually make that concept real?
Just let me confer for a second.
Sure.
Lindsay.
Yeah, can you clarify what you mean by upstream?
Well, I mean, more preventative or early intervention. I mean, I'm thinking, you know, is there a way to sort of get better assessment and treatment among children, let's say, in our primary schools? Like, if we want upstream interventions to reduce the rate of hospitalizations to kind of get it early, how do we make that real? What do we do?
Yeah,
Okay, so we have in this country a heavy emphasis on diagnosis as opposed to just assessment and evaluation, and I think, you know, counselors, psychotherapists are able to assess. So if we broaden that ability, we have, you know, guidance counselors are also a part of the CCPA system, and perhaps if we can broaden that, then we don't have to wait for one psychologist per school board to make it to all the different schools. I think that would be one way of getting early diagnoses earlier on, and also just, I mean, clients that call me and are looking for help for their children that have ADHD, for me, do they need actual special input in the school and special parameters put around their learning and their learning difficulties so that they can achieve? Or is it because they just want to work on some of the psychotherapeutic that needs the counseling aspect? Because they can't see me for the diagnosis, but they can see me for the betterment, for the mental health care.
Ms. Foster,
One
Mr.
point,
Davies?
if I may add to that, just to further Carrie's point, absolutely increasing the availability of psychotherapists within the schools. So I have had the opportunity to do my bachelor education and actually be in schools and learn that, as Carrie mentioned, that there are guidance counselors available, but often, at least in the context of my experience being in Toronto, is that you'll have one guidance counselor for 5 schools. You have 500 to 1,000 kids, children per school. How much one-on-one time are they actually getting, right? So, and not just doing, career counseling and how are your grades, but like how are you actually doing in terms of your mental health? So that's one piece. The other piece I see as well, which could bring us in a whole different.
Ms. Thompson,
yeah.
We want to try and make sure that everyone gets a chance here.
Of
so
course.
we're well past time. You'll get a chance to come back to it, I'm sure.
Okay,
Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. As has been the case in many of our panels, we have a variety of different witnesses that have very different specializations, which makes it really difficult to try and figure out which angle we're going to go with this. And I think this is part of the struggle with this very vast study that we have on children's health. Well, children are a large demographic in our country, and yet we're just studying children's health, which can be everything from autism to mental health to access to care to everything in between. And I think it makes it very difficult for us as parliamentarians to figure out exactly how we're going to take this, because it's all important. And one of the things I guess I'm going to start with, and I'm going to apologize in advance because I'm probably going to butcher your name, but Dr. Georgiadis, I was reading the study that you had produced in 2021 on screen youth and mental health symptoms in children and youth, and I thought that was extremely poignant, and I was just wondering if you could expand a little bit on that.
Thank you, and that was a very good pronunciation of my last name. So I want to start by your comment about how broad child health is and how challenging it is to come up with an action plan, which may also touch on screen use and mental health, especially during the pandemic. I agree with that. I have to say that in my opinion, I've been in Canada for 27 years. I have never seen a study like the one undertaken by your committee right now. You have experts and witnesses that testify, but your committee and your teams now have information and testimonies that can certainly guide us for the way forward. So I have to say, even though it's broad and challenging, I am very encouraged by the work of this committee and the opportunities that may come out of this study. In terms of screen use and mental health, it is not my expertise. That is a study that's actually co-led by another Dr. Georgiadis at McMaster, Kathy Georgiadis.
Apologies. I will skip past that. I clearly did not prepare as well as I should have. But I guess to go back to, you definitely are a specialist in autism, and one of the things that we've heard very clearly is that early diagnosis is important. What are you guys seeing in terms of backlogs, especially in terms of COVID and how that impacted being able to diagnose children earlier?
Yes, autism is a great example of children with multifaceted needs, and early diagnosis, we know this based on several studies. Early diagnosis, earlier access to intervention can certainly lead to improved and more optimal outcomes. There's no doubt that the pandemic has limited the rate of diagnosis across our country, a rate of diagnosis that was already slow before the pandemic. So I think some of your other witnesses talked about, many of the issues being there prior to the pandemic and exacerbated because of the pandemic. At the same time, I will say that autism is also a positive example because it is one area in our country where I have personally experienced what collaboration and unity across scientists, clinicians, stakeholders, families, but also politicians and policymakers can do. So there's a backlog, there's no doubt about that. But we are in the process working with many stakeholders from across Canada on developing a national autism strategy that will use innovative, effective, and efficient ways to clear the backlog in the years to come. So that's an example of both a challenge, but also an opportunity on what collaboration across jurisdictions and across political parties and across specializations can actually achieve.
I don't want to interrupt, but I think I have about a minute left. No? All right.
You had 5, and that's 5.
Okay.
Thank you very much, Ms. Goodrich. Next, we're going to go to Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. I also want to express my condolences to the families and friends those affected by the yesterday tragedy in Lowell. My first questions to Dr. Afifi or M. Thompson. You talked about there's a five schools, there's one guidance counselors are there. What role schools can play? How can early childhood education programs be designed to support healthy development and resiliency in the children?
With that, I'll say I'm not an expert, so I'll be going based off of just the research that I've read in my experience in thinking about, working with children from a mental health perspective. The thing that I can think of and that I've heard from, educators, our school counselor educators through the CCPA is actually having part of the curriculum learning about what it means to be human, right? How to be able to regulate our emotions, how to be able to communicate, how to be able to express anger, frustration in a healthy way, right? So just kind of making some space for that type of education so we're not left until, okay, now I realize I have an anxiety disorder. I don't know what I'm doing. I'm 30 years old. I'm starting therapy for the first time and trying to figure it out while also managing maybe a single income household with 2 kids, right?
Thank you. And Dr. Fifi, you want to add on that?
Sure. I think that to make it extremely concrete and simple, it's early intervention is key. So we can access children through schools early, and that's really important. It's evidence-based. So we need to make sure we're putting programs in the schools, and there are many out there, the Good Behavior Game, for example, where you can implement to improve evidence-based to improve mental health for kids that is run through schools. So early intervention, evidence-based, and access to care. So those are the things that we need for all children. So that this is equal for every child that needs it. If we can prevent things from happening before they happen, then we're going to have better outcomes. So those are the things that we need to do. But we also have to, and that's where data is involved. We have to make sure that and also previous question, how do we know we're making progress? How do we know we're improving things? It's data. Everything is based on evidence and data. We need to, if we don't collect the data, then we don't know if what we're doing works. So the recommendations I've made actually try to incorporate many of all of the things that we're talking about today: evidence, early access, and more access to care.
Thank you. I understand there's a stigma in certain cultural communities. How can we reduce stigma and support a more open conversation about mental health? And if you can add the both on the point, like what you think about integrated services as well?
Yes, so we need to integrate our services. We can't be working in silos. I think that's really important. It's important across, things like child protection and health. We need to have integrated services for sure. That's our best efforts. We need to continue to talk about mental health and reduce the stigma, but we also need to just have those early conversations early on with children. And as one of the other witnesses said, we need to be checking in on children. We need to be giving them the tools and the language and their own ability to identify when they need help. So these feelings that they have inside might be anxiety. They might not be able to identify them as anxiety. So if we kind of make it as normal, we all have these feelings, and sometimes anxiety is healthy and helpful, and sometimes it's too much and it makes things harder for us. Giving those children the tools to know that these things are normal and healthy reduces the stigma. And it also gives them the ability to communicate to us instead of having it come up in unwanted behavior or other problems that it might take some time for a teacher or a parent to recognize, oh, this isn't a defiant behavior. This child's struggling and it's with a mental health problem. Is it anxiety, depression, whatever it may be? And it's surfacing in perhaps a behavior that is identified as unwanted.
Counselors and psychotherapists also are trained in cultural humility, and I think that's a big piece that's needed to be addressed, and that is just being able to speak and understand and inform yourself as to the cultural ethnical background of your client so that they are being addressed and helped in terms that meet their language, that meet their cultural values. So I think that's a big piece. And is there anything else you wanted to say about that? That was it, yeah. Excuse me?
The integrated services, one-stop shop.
A one-stop shop?
The integrated services, the psychotherapist, psychiatrist, social services.
Well, I think teamwork is always important in terms of who can do what, but one stop hopefully is there if it's a good fit, right? So if I'm needing a drama therapist as opposed to a psychiatrist, that I'm getting that kind of, or a play therapist, I'm getting my needs met for my child or youth. Right,
Thank you,
so
Ms.
it's
Foster.
not necessarily a psychiatrist that's going to be helping my child and being able to access their need through talk therapy, but there are other methodologies that are out there that we need to be more inclusive of. Yes.
Thank you, Ms. Foster. Monsieur Garand pour 2 minutes et demie.
I want to continue with Ms. Foster. I have in front of me a 140-page document. It is the Interministerial Plan 2022-2026, Quebec's Mental Health Plan. And under number 4, we have all the programs or actions over a 4-year period for families and children and new financing. You are in Quebec. I expect you've read that document. Inaudible. Ms. Thompson, have you read this? No, I have not. We work with clienteles. Well, if it were a good plan, well-funded, 140 pages, ready to implement, that would be a plan that could be implemented by the government. I would certainly be interested in reading the document, and I can pledge that I will read it. I hope that it would include professionals in private practice, family therapists, couple therapists, because at this time that is not included in Quebec. Well, I'm always accused of posing the same questions. There is this trend in Ottawa that people think that provinces don't have standards, and that might lead one to believe that in Quebec children are not important. So I just want to say I have a 140-page document in front of me. And this is not for lack of courtesy, but I would have liked to been able to discuss the document here. Now, the taxes that apply to psychotherapists, the sales tax does apply? Yes, it does. So, in your opinion, with the harmonized tax, that should be eliminated? I'm just wondering, in Quebec, we do have a labor shortage. There's a need to train more professionals. Well, yes, for psychologists and psychiatrists in Quebec, we have counseling therapists, psychotherapists who are ready to work. But the way that Quebec is organized with its professional orders, these services are not necessarily covered by the orders, so the public doesn't have access. So we need more resources.
For 2.5 minutes.
Thank you. My information is that less than 20% of youth who need mental health services receive appropriate treatment. Does that jibe with your sort of practical experience?
Yes, and I can tell you my waiting list is about 2 years long at this point in time.
I think it's fair to say that there's been a societal shift and maybe hopefully a political shift in the last, say, maybe 10 years, where we now recognize mental health to be a core part of overall health and not any different, really, than physical health. Yet we clearly have we are not providing treatment to a huge number of our citizens, and of course, as we're studying children, who are, I think, among the most important people in our lives often. we're letting them go untreated for a significant part of their health. My question is this: is it time to bring access to mental health services under our universal health care system so that everybody can get treatment when they need it?
That's my dream. I think absolutely, that's what we would hope for.
Ms. Thompson, you were nodding. You would agree with that?
100%.
Other witnesses, I'd like to open that up to you. Dr. Afifi, would you agree with that?
Absolutely. Absolutely, we need to do that.
I want to take a crack at this. Mr. Georgiades, would you agree with that?
Thank you for your comment. I think the big question is, why wouldn't we include it?
I don't know how much time I have left, Mr. Chair. 1 minute. So interestingly, there was a large cross-sectional study conducted in 2020 of Canadian children, youth, and parents, where 67 to 70% of children and adolescents experienced deterioration in at least one mental health domain: depression, anxiety, irritability, attention, hyperactivity, OC disorders. But 19 to 31%, depending on the age group, experienced improvement in at least one domain. Do any of the witnesses have any comment, perhaps Dr. Afifi, what factors might explain this heterogeneity of experiences among Canadian children?
Yeah, I can speak to that. It depends on what the outcome is that you're looking at. And for some children, their home environment in which they were, captured in, for lack of a better phrase, at home, for some of them, it may have improved. They may have got one-on-one undivided attention from their parents who were able to stay home and take care of their needs. So some things may have increased. For some children, their needs might have improved being in the home environment through the pandemic and homeschooling. But for most children, and for those who, when we think of those who have the least amount of resources, the families with the least amount of resources who couldn't provide that, they were struggling, they were trying to make, do their job and trying to find adequate care and adequate education for their children, those are the children that would have suffered the most during the pandemic and perhaps have been left behind. So I think it depends on the circumstances and what outcomes you're specifically looking at in terms of saying what went up and what went down.
Thank you, Dr. Afifi.
Thank you.
Next, we're going to go to Mr. Generou, please, for 5 minutes.
Thank you, Mr. Chair, and thank you, everybody, for taking the time to be here today. I'm hoping to get to at least two themes in my 5 minutes that I have here, but we'll start with the first one. Both you, Ms. Thompson, and you, Professor Afifi, had touched on the importance of intervention with our children and the reasons of doing that at an early stage. I've had discussions with some policymakers about the importance of things like ADHD and dyslexia, and whether or not certain education systems should be looking at making that screening mandatory. Wondering if there's from your research, Professor Afifi, and then to you here in the room, wondering if there's some of that perhaps falls into your realm and that you've seen has been a success, maybe not necessarily here in Canada, it could also be elsewhere, but looking for some of that. Maybe since Ms. Thompson's writing, I'll go to you, Professor Afifi, first, and hopefully get some of your thoughts.
Yeah, I think that we need to be careful in terms of just universal screening and not just implementing universal screening for a variety of things unless there's proven reason why we should. So first of all, screening needs to be done if we can adequately identify what the problem is. But then most importantly, if we're screening children, then we are obligated to connect those children who screen positive for whatever the outcome is to services. If we don't have those services readily available and in place, then the screening is actually for nothing. And it could actually cause more anxiety for families, because now we've identified your child may have ADHD, but we don't have the resources at the school or at the province or in the community to support that. And now you have to wait 2 years to get access to care. So I think we need to think that through carefully. Early intervention, and if that connects to screening, then yes, we should do it, but we should only do it if we are able to connect that. So think about it for screening for cancer, for example. Imagine being screened for cancer and you're told you have cancer, but then you're told we can't give you services for 2 years. You're going to have to wait. Imagine how much worse off that situation is. So there's an obligation there when we screen to connect to services and make sure that they're there. So again, all the recommendations tie together: data, evidence-based, translate that information into policy and practice, train and retain people in an integrated system that talks to each other, and then make sure all of these services are accessible to every single child, not just certain children, no one left behind.
Before I go to Ms. Thompson, I don't think we're going to unpack all of that in the 5 minutes that have, but I see Dr. Georgiadis also nodding along. I fear I might not get to you in this round, Dr. Georgiadis, but certainly if there's more of that, welcome that to be submitted to the committee, because I think it's as a philosophical and I guess ideological conversation about the importance of what we do. Do we just live not knowing that a kid has ADHD then, and because we don't have the services for it? That also seems like it's not necessarily the compassionate answer. So before I take up more of the time, I'll turn to Ms. Thompson to perhaps finish this theme.
Absolutely, thank you. I definitely echo what Dr. Afifi is saying, and to add to that, what we can see among the psychological tools that are available for doing different mental health diagnoses is that they're not all appropriate across the different cultural experience and ethnic background. So that's something that we have to bring extra attention to. If this is something that would be, implemented, we have to look at, depending on the makeup or the grouping of the children, right, in their backgrounds, is this going to be appropriate? Are we going to be pathologizing their experience that they might not necessarily identify with?
Great. Well, maybe I do have time for Dr. Georgiadis. I have 30 seconds, right, Mr. Chair? If you can wrap all that up in 30 seconds, Mr. Georgiadis, would be great.
I think if we think in a limited way in terms of capacity, resources, and strategy, I completely agree with Dr. Afifi that we should be very careful. But in the Canada that we all envision, especially the ones here today, capacity, resources, and a clear evidence-based strategy will be in place where screening is matched with diagnosis, is matched with timely interventions, so that our children and youth can reach their full potential.
Thank you, Mr. Genero. Dr. Georgiadis. Next, we're going to go to Dr. Pawlowski, please, for 5 minutes.
Thank you. We're here to talk about child mental health, and we've already talked about some of the barriers. And I'm going to build on Don's question. Don had 2.5 minutes, and he got right to the punchline, but I'm going to kind of provide some of the build-up to that. What percentage of children do you treat have the costs of that treatment coming directly from government-provided services? And under what programs would they be?
That would be under EVAC, Victims of Criminal Violence. It's a provincially run program. That would be under the NIHB program. That would be also under the program for Ganawage Social Services Centers.
And what percentage of children would their costs of their psychotherapy be covered by insurance plans they have, and what percentage of those does it actually cover the whole costs?
As a psychotherapist and Canadian certified counselor, and not a psychologist or even my colleagues in my order, social workers, I probably have maybe 15 to 20% of my clients that are covered through insurance plans. The rest, if they're in financial need, I take that hit. I reduce my services given their paying ability. Yeah.
Okay, so I'll get back to that question. So Dawn asked the question, and you've already answered. You would support government providing, paying for the costs of this psychotherapy, and Dr. Giorgades said, why wouldn't we? I think the obvious answer is cost. Have you or have any of you figured out what the total cost would be if the government was to provide these services as part of healthcare plans?
We have looked at that here. I did some research because I was called into this meeting on Monday, and I had full clients, and I had to switch them all so that my Thursday is free. So forgive me if I don't have in-depth details, but basically for every dollar you spend, you would be saving $1.37 to $1.78, I think it is, from memory. Those numbers, I don't even remember where they're from, but I'm sure we could get those to you. I think the important part to remember, and we've spoken to this earlier, is that is more preventative measures that we take in the long term, we're cutting back on costs. And the other most obvious answer is, can we afford not to, as was already said, and how can we put a price on people's and children's health and well-being? I have a really hard time with that.
And now I hate to bring this up, but it's come up. You brought it up. The 5% is being a barrier to access, but
15.
How much? Well, our part is 5% from the federal government. But I think the obvious question is the other part of that, which is how much do psychotherapists charge children for psychotherapy?
Can you speak on that?
You want to speak on it? And I can follow you. Sure.
So the cost for psychotherapy services varies greatly depending on where that psychotherapist is working. So if they're in private practice versus government setting versus, community program. So the more complicated answer is it really varies. It can really, from what I've seen in my experience, it can range from $80 an hour to $180 an hour, depending on location, type of treatment that's being offered, family setting versus individual setting, right? So it varies greatly. A lot of psychotherapists do, as Carrie mentioned, take a hit to their own personal finances, right, and offer a sliding scale too.
Yeah, absolutely. And if I could just add 2 seconds, that psychologists, psychiatry is going to cost more. Maybe not psychiatry because it's covered under the card, but definitely psychologists are up to the 200 and something. So if we can add more psychotherapists in, and if insurance companies can cover them, which they won't want to because it's more out of their pockets, then
maybe to the other two witnesses online, if you have a few seconds in order to address the question of, is this a good expenditure of government money? Does it save us more money in the long term?
Absolutely, it would save you more money. The cost of not doing this in the long term will have impacts on education. People will not finish their education. They'll not be able to get jobs. There's justice costs, child protection costs, and down the road, there will be more mental and physical health costs to the healthcare system. So not doing it early will actually cost the government more money in the long run, and that's quite certain. And so we need to provide this investment now.
Thank you, Dr. Pawlowski. Next, we're going to go to Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here, and I do appreciate your comments. And basically, we see practitioners versus academics and researchers at the table, and I do appreciate it. And having lived in that world before I became a politician, it's been very interesting. I was the registrar for the profession in Saskatchewan, as well as the president of the National Regulatory Body for Canada. So I understand a number of things. So I have so many questions I want to ask. But I'll start off with asking just to you, Carrie or Lindsay, has there ever been any discussions with insurance agencies as to whether they would turn around when they say, for example, $500 of coverage for psychotherapy, that we only cover the cost that the practitioner charges and not the GST, HST in it? Has there ever been any discussion with those agencies at all?
No, there's been discussion with them, but not on that particular point.
Okay. I mean, that part would actually take that out, where it's now the insurance companies are saying, okay, we're going to get 500, and so ultimately someone that's charging $100 for an hour maybe gets five treatments versus 4 because of the GST, HST.
The bigger picture would be to get the insurance companies to cover psychotherapy and counseling.
True. I mean, but I'm just throwing that out there. Secondly, and perhaps for not only for those on the committee here who don't understand it, or even the people that are listening are going to read the report, can you quickly explain the differences and the educational levels that you need to get to the level of training that you have? In other words, what programs you go to, and for example, if we're talking psychologists, psychiatrists, psychotherapists, counselors, social workers, that aspect are all dealing with mental health. Can you just quickly, in a very brief, explain
I can speak especially for Quebec. In Quebec, you can have a master's in social work, a master's in couple and family therapy, a master's in psychology, counseling psychology. That will get you into the CCPA. That will get you your psychotherapy permit in Quebec only if you have enough psychotherapeutic training. So couple and family therapists, 100% or 98.8% of them are psychotherapists as well. And for the social workers, you just have to have a BA to be a part of that order, so they will not have their psychotherapy permit, so the level of deep work, psychological work that you can do is limited. But counseling therapy programs across Canada are master's level for entrance into the Canadian Counseling and Psychotherapy Association. That's, accreditation to get your certified Canadian counseling certification requires extra hours and making sure you have all those checkpoints. They're pretty much on the same level as many of the other. In Quebec, we have so many orders that do or don't get their psychotherapy permit. But they're on par. I mean, I have two masters, one in science, one in art, one in the creative arts, and one in couple and family. And most people I know have like their psychoeducation, and they have another social work degree or something. So there's a lot of, they've got 4 years of a master's level or master level courses to be able to work. And we have ongoing regulation with the CCPA to make sure that we have all of those add-ons. And then those add-ons are things that you need, the ethic courses, right, the cultural awareness, and so on.
Okay, thank you. And just for correction, they're regulated in 5 provinces in Canada, is that correct? And,
that is correct.
Okay, and are they up for regulation standards in the others and the territories?
Yes, that's all in process.
Okay,
in
great.
Newfoundland and in British Columbia and Manitoba. We're all across the country.
Thank you very much for that. On the issue, when we look at a number of things, and ultimately when we talk about children and mental health of children, we're talking 0 to 18. And the tragic incident that happened yesterday in Laval, obviously there's huge impact on not only the families, but those siblings, et cetera, and young children. And I come from Saskatchewan, and as you're well aware, the Humboldt bus crash that happened, and unfortunately I lost a very good friend in the head coach in that accident, but also there were a number of hockey players that were impacted on it, and particularly from my community, young Adam Harrod, who was 16 years of age and who passed away in that accident from Montmartre, Saskatchewan. And so those are tragic things that impacted a lot of kids. And what we heard on Tuesday, we heard about the value of sports and the value that provides in the mental health aspect of young people, to get them involved and get them active. And so, I mean, these are things that we need to look at. I know kids that I used to travel those buses as a coach and all over Saskatchewan in those buses. So I know children getting on buses today, hockey players are looking at this saying, okay, and not just hockey, but other sports, could something like this happen? We recognize the need for accessing treatment as quickly as possible. The faster we do that, and to do that. Just when we look at the government saying it's $4.5 billion put to mental health, yet appears to not to have even got to that stage. And in fact, I think I heard there are 825 million that have not even been spent by 2022. So where does that money go? How do we get that money out to the practitioners on the floor so that we put boots on the ground so we can put that access, as opposed to putting it out there where it sits up in creating more and more bureaucracies?
Ms. Foster, sorry to do this to you, but Dr. Kitchen actually went past his time with that very verbose question. A succinct answer, if you could, please. Go ahead. Take 30 seconds.
Go ahead.
Oversight committee. Have some kind of structure and oversight to be able to actually have accountability, see where the money is flowing, and ensure that it's not being left in a pot and leaving Canadians high and dry. Having different hubs in different locations, rural, urban, right, and having some kind of structure to be able to look into that.
Thank you. Mr. Vancouverden, please, for 5 minutes.
Thank you very much, Mr. Chair. Thanks to all the witnesses. I echo the condolences of my colleagues earlier, yesterday's tragic crash. I'd like to start by saying that I've emailed back and forth with a practitioner named Kevin Green, who's been a big advocate for the removal of HST on psychotherapy in Canada. So I feel like I've, in reading his emails and the deck that he sent me, I've also had some conversations with folks in finance and trying to understand the costs. Anytime a tax is eliminated, it is an obvious cost to government, and sometimes the cost to government, is way larger or way bigger than the amount they invested. And I think that's an important consideration if we're talking about millions or billions of dollars here or there. But I think personally that social costs in the long term greatly outweigh any investments that we can make in kids today. So my questions are going to be primarily around resiliency and building resiliency in the early years for children. First, is there any research indicating the impacts of access to sport, physical activity, and recreation and positive team experiences for kids that lead to better? We've all been there, Dave. Don, no worries. Any research that indicates a positive access, positive influence on children and their resiliency, particularly around mental health, when they have access to sport, physical activity, and recreation programs?
Yeah, so I can speak to research in terms of the impact that recreation and movement has on our mental health in general. So I have to find you the exact reference for this, I can send it to you after. But research has actually demonstrated that if we do a control group versus an experimental group of looking at the impacts of taking, let's say, medication for depression versus a group to look at the impacts of movement, that in the long term, sustained and regular movement, you don't always have to be going to the gym, but just getting out for a walk is actually more effective than medication alone. And so we can naturally translate that to the importance of being able to have recreation for kids.
Thanks. I might turn to the researchers on the Zoom for that same question.
So I've done work in that area exactly, looking at what protective factors might be related for those who experienced trauma and adversity to better mental health outcomes and substance use outcomes. We look at it within the individual protective factors at the individual level, school, family, community as well. We have found in a number of studies that physical activity and sense of belonging. So it could be belonging to a sports team, having that sense of community does have an impact on reducing poor outcomes. We see it for both kids who have experienced trauma and maltreatment, but sometimes the effects can be larger if you have also experienced that trauma and maltreatment.
Thank you, Dr. Afifi. I'd note that it's Winter Health and Fitness Week right now, and Tuesday was ski day on the hill, and I skied with I would guess 13 or 14-year-old girl named Ella, and I asked her why she loves physical activity, and she said exactly what you just said, that it helps her deal with anxiety, helps her set goals. She's met all of her friends through sport, and it is that protective mechanism I would draw from that conversation. Secondly, I just go on to anecdotally, so perhaps more towards the clinicians, less on the research side, but more in your experience in dealing with kids who have equitable access to sport, physical activity, and recreation. Do you see better outcomes for those kids?
I know I've worked at the Jewish General Hospital in Montreal, running a group at their day program, running a group of 10-year-old boys using drama therapy, and definitely the improvements that were seen by their teachers ongoingly were clear. I've also done drama therapy again online with young adults that were depressed during the pandemic, and we did MRI scans. It was through University of Toronto, and those MRI scans proved that the work that we were doing just online, just the connection, was in fact effective. So that's really great to hear. We have a lot of that physical, that's one of the things I do is somatic work as well. So a lot of the somatic work that I do is actually getting people into their bodies so that anxiety does come down.
Thank you. And just very briefly, would you consider drama a form of recreation?
Drama, yes. Drama therapy is therapeutic focus.
Okay. And just very quickly, Dr. Afifi, you mentioned the legality of corporal punishment, and you mentioned that the only kind of legal way that people can hit each other is in the criminal code is when parents hit their children. I'd also note that there's a social permission in the game of hockey that we've all sort of allowed to watch and see, and a lot of young kids really love hockey, and there's bare knuckle brawling in the game of hockey, which is the main reason why I don't watch NHL hockey generally, because I find it incredible that grown men are just punching each other, and it's totally normal. If it happened in front of a bar, then they'd both be arrested probably. So it's just a interesting thing. That's not bare knuckle. Thank you for the commentary, though. Anyway, how does that impact young boys that watch hockey and love the game?
Very briefly, please, Dr. Afifi, we're out of time.
Very briefly, I agree. It is assault on the ice in some cases, and it affects all people who watch hockey. I hate it as well. I wish that could be changed, but that's, I guess, up to the NHL and the NHL Players Association at this point. But I completely agree. It's still assault on the ice, and it's violence that we shouldn't be watching.
Thank you. Suite, Monsieur Garon, pour 2 minutes et demie.
Thank you very much, Chair. A question for Dr. Georgiadis. You mentioned earlier that it is a good initiative to conduct a study, and then we'd have a written document to guide policy. Do you have any other documents produced by provincial governments that have responsibility for healthcare that could guide us in our thinking on these issues?
I am sure that we can identify those and submit to the committee. I'm going to go back to the example of autism again, which is, I think, a model that can be used for the development of a national strategy for child health more generally. And that is based on consultations with provinces,
Monsieur le Président.
Mr. Chair, if you allow me, it is because we're told it's never been done. We're told it's the first time we conduct a study, the first time the committee, the government shows interest in children's health. It's normal. We're in Ottawa. Now, I ask of the 10 provinces, and we're told in committee by experts. Then I ask the expert, are there any other documents, study, projects? And I talked about Quebec's interministerial study, 140 pages. And then the answer I get, we could examine it eventually when it's timely. And by the way, it takes national strategies for this and that. So I'm going to ask the question one more time. Is it yes or no? Before, we're told that the job has never been done before, including the governments who have the responsibility. Have you done the research, and what did you base yourself on, given what you told us earlier?
So absolutely, many provincial studies and governments have produced guidelines for child health. I think what we're lacking in Canada is learning from each other across provinces and across regions in a national scope. That's what's lacking here, and I think that's why this committee is here today.
Donc, les provinces.
So, province has already done a part of the work that we are doing today, contrary to what you said earlier.
So the different pieces may be there that we can build on. Right? The committee that we're here today is to learn from each other so that all kids across Canada can benefit from evidence and learnings. That is my point.
Thank you, Dr. Georgiadis. Next, Mr. Davies, please, for 2.5 minutes.
Touched on this issue of exposure of people to imagery. I'm curious about the association, if any, between the internet and social media exposure of children to, say, age-inappropriate images, acts, or concepts, and whether there's been any work done to link that to increased mental illness in children or psychological dislocations. Dr. Afifi?
Oh, sorry, I wasn't sure if it was for me. So in terms of social media content that they see, or in terms of bullying via social media, just to clarify?
Well, I suppose anything. I mean, I'm just wondering one difference between children, let's say, growing up today than most of us in this room, if not all of us, is that children are growing up with the access to the internet and exposure to images and acts and concepts that may be not age inappropriate. I'm just wondering, is there any link between that?
Yes.
And
yes. So some of there's research on content that they see that has an impact, which is not my research, on an impact on self-image. There's research showing increases in anxiety and depression related to content that they see in social media. The work that we've done in my lab is looking at how social media is related to peer victimization and bullying. So if they see and hear things being bullied online, whether that's through texts or through social media, and all of those things have increase in poor mental health and also increase in substance use among youth and children.
To the association, I'm curious as clinicians, what trends in childhood mental illness you're seeing. Are there any significant increasing disorders that you're able to tell us about?
ADHD, eating disorders, definitely. Also, compulsion. I have a lot of clients with OCD, aged 5 to 12. Depression, anxiety.
Absolutely, eating disorders. In my work, I work with women who experience eating disorders on the spectrum, and from the clients that I've worked with, they've said that they've struggled with this from a young age, and bringing that back to social media is a huge cause of eating disorders amongst young women.
Thank you, Mr. Davies. Ms. Thompson. Next, Dr. Ellis, please, for 5 minutes.
Well, thank you very much, Chair. I appreciate it, and really appreciate the interesting discussion around the table. I had a question for you, Dr. Georgiadis. My colleague talked a bit about transparency and accountability and funding, and that being the reason, of course, why $4.5 billion has not been sent to the Canada with respect to the Canada mental health transfer. Anyway, I have a whole bunch of comments about that. I'll keep those to myself. That being said, I guess I wonder, do you believe at the current time that we can find system or areas of interest currently in place that have enough data and that we could actually stream funding to at the current time that would make sense? I mean, obviously, there's a significant need for funding in mental health, and I guess I find it difficult to believe that there are no mental health areas in the country that are transparent and accountable and that could actually use money. I think there's lots out there that could and could fill that bill very quickly. Do you have comments on that, Dr. Georgiadis, please?
So in principle, I think making sure that funds are allocated to address the needs of children across the country should be a priority. Now, I understand the points about transparency and accountability, but I don't see those as limitations. That is something that that can be worked on, and there's definitely ways, if there is will and collaboration, for us to increase the resources and take targeted steps so that we can actually support children and families on the ground.
Georgiadis, if to be clear, at the current time, if the government said we're going to today fund the Canada mental health transfer to $4.5 billion, you feel there's systems out there that could readily accept that money with transparency and accountability?
I would say there's stakeholders that could come together and form a network of systems that can actually implement something like that with a rigorous way and transparency and accountability.
And through you, Chair, Dr. Fifi, we talked a bit about violence in hockey in particular, which is interesting. There's many other sports that are violent. I guess one of the concerns I've had, as a family doctor for many years is about the violence in video games. I would suggest that many more children are exposed to violence in video games, especially, very sadly, in an isolated setting. And what I mean by that is that they would be playing video games often alone, experiencing those things. I'm certainly not sitting here arguing for violence in sports. That's not what I'm suggesting. But what I would suggest is that experiencing that very, very graphic violence in an isolated setting is perhaps something that is even more damaging, if there is such a thing. Do you have comments on that, Dr. Afifi, please?
Yeah, I understand how the violence in video games can be very common access to children, and that many children do play those games, whether it be in isolation or online with their friends, and they are very graphic and can be very real in certain cases. Whether or not one is worse than the other in terms of watching hockey or versus video games, we don't know. We don't have data. We couldn't comment on that. But I think most importantly is really understanding home environments. And that's what I mentioned in my opening comments, is that we have to do all this work within the context of understanding the environment in which a child lives, works, learns, and plays. And that is included in that. And we need to understand the relationships, and I focus on not only violence that they witness or are exposed to, but more importantly, we need to really focus on violence within that they experience at the hands of caregivers and other people in their lives. So the entire context of violence is important.
Dr. Fifi, through you, Chair. The other day I was watching television in French and noticed very clearly that there were commercials talking about violence in the home on French television, which normally I watch English television, and certainly I live in Atlantic Canada. We don't see any of that advertising there, explaining the inappropriateness of it and being very straightforward with the messaging. Do you think that style of messaging is important, and should that be something that we see again in both official languages and, of course, in languages that would be appropriate for marginalized and racialized communities as well?
I think we need a multi-faceted approach, and that could be a universal approach to explaining what is and isn't appropriate, and connecting families to resources to support them would be great. Repealing Section 43 is one part of that. So there's many things we need to do. Education is one of those things. So yes, I think it would be helpful along with many other things that would be needed for violence prevention. But I think we could actually make great progress with a national plan. And over time, that alone, I think if we could reduce or eliminate violence in childhood, that alone will, over the long term, show improvements in child health, both mental and physical.
Thank you, Dr. Afifi. Over to Dr. Hanley for 5 minutes.
I want to thank everyone for coming today. Really interesting discussion. I want to maybe just pick up on the funding question and how that might follow through. We know that with the previous $5 billion transfer, or we don't know. I think the question is, we don't know a lot about where that money went. And I think the question is not, I haven't heard anyone, including the Prime Minister or the Minister of Health, say that we don't need more funding into mental health. It's a matter of how do we ensure that it gets there and gets to where it's needed. So I, for one, am really looking forward to the bilateral health negotiations. And I imagine that mental health will be identified as a priority area for most, if not all, jurisdictions when it comes down to that. So one of my questions, to follow up on some of the discussion about coverage, to Ms. Foster and Thompson very briefly, do you think it would be reasonable to have access to counseling and psychotherapy on the table as part of what should be covered in universal health coverage if when it comes to bilateral health It also brings up the question, I know when I've talked to some clinics in my jurisdiction in the Yukon, in similar settings as yours, they are facing similar circumstances. People who do not have coverage, they are taking a hit. And then that in turn seems to affect their ability to resource themselves. So if they did have access to increased public health coverage, it might enable them to increase or build their capacity to meet the needs of the community. In other words, hire more people, have a fuller roster, as it were. Would that reflect your own experience?
Yes, and I would also add to that to have appropriate, especially in the Yukon and Northern Territories where there are a lot of Indigenous folks, that it would be really important to be able to have a good fit therapy-wise, to allow people to then be able to re-engage in community and be functional.
Well, thank you. I think that anticipates my next question, which is really, I think it would really bring into importance both the concept of mental health literacy and tiered care, like who gets what level of care and how do people know how to access that, so that we can really have the most efficient delivery of mental health care, and also tools for self-management, family management. I wonder if you might comment on that area briefly.
So stepped care is a model that's currently being implemented. I can speak at least to the context of Ontario. A lot of research has been done in the UK to be able to determine where is someone at in terms of their needs. Can they do bibliotherapy, which is maybe, doing self-directed learning? Do they need to work with a psychotherapist or a social worker for talk therapy? Do they need medication management for more severe mental health diagnosis, right? So that's absolutely something that we would like to see as a part of that system.
Thank you. And on the subject of NIHB, you brought that up, and of course that's a very important area in my jurisdiction. You mentioned that there is coverage during the pandemic for psychotherapy and mental health services.
And certified Canadian counselors.
You would like to see that continued, that NIHB continues to cover.
Because it was present up until 2017, I think it was.
Okay, so
we'd like it reinstated permanently.
Permanent reinstatement would be beneficial for our First Nations and Indigenous
First Nations
children.
and Indigenous, yeah.
Thank you. And I would like to turn to Dr. Afifi. You mentioned, I think, almost in passing, I think a relationship between childhood stress, toxic stress, I believe, and chronic disease outcomes later in life. Could you comment on where we are in the research and understanding of that relationship? Because I'm not sure it's very well known or understood.
Mm-hmm. So there's a lot of research that has been done at looking at how stress has an impact on the body, and whether or not, some stress in certain situations is adaptive and healthy and good. But the thing is, we need to, for some children, they experience chronic stress. They don't get relief from it. They don't have someone to help them to process that stress or to leave that stress. So they're in a current state of hyperarousal, or their nervous system is always engaged. They always have that hyperarousal. When you live in that state, your heart rate is elevated, your blood pressure is elevated. You have many, many different impacts on your physical health and also on your mental health. So living in that constant state has a long-term impact on health. And so there is a lot of evidence to show that it can have increased likelihood of not only physical health conditions, but also mental health conditions as well. So, and often children who live in a home where they experience violence, they're always in that hyper state of arousal of chronic toxic stress.
Thank you, Dr. Afifi. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. And again, thank you to the witnesses. When we were talking about the importance of sport and activity in children, it kind of triggered something that's been pretty active in the news as of late, and it's the very serious allegations of abuse that have been coming up specifically from around Gymnastics Canada. And particularly, Ms. Thompson, when you were talking about eating disorders, and I know we've heard so many situations where some of this abuse has led to lifelong eating disorders in some of these gymnasts. There are allegations of sexual abuse. And I'm just wondering, as much as, yes, activity is very important for kids, in situations like this, when there's extreme abuse being reported and alleged, how does that impact children?
Just makes things worse, right? When we're talking about the context of organized sport, I guess what I didn't say was that we're assuming that it's a safe environment, and we're assuming that it's an environment for growth and development. And so absolutely, if you're, just kind of building off what Dr. Fifi was just talking about, if you're in this constant state of fear and you have all this cortisol constantly running through you, right, that's going to lead to a lot of mental health challenges. The piece specifically around eating disorder, which is very common, is that everything in my life is so chaotic, I have no control. Food is the one thing I have control over, to take back some of that autonomy and some of that self-determination, right? So that just gives you a little bit of insight as to maybe a little bit more clear on where that link comes from between those two parts.
Okay, so would you be supportive of the idea of having an investigation into the allegations, an investigation from the Government of Canada into the allegations on Gymnastics Canada?
Absolutely.
What about you, Ms. Foster?
Absolutely.
To the other witnesses?
Anytime children are at risk, we need to protect them, and so there's we always support. I would always support anytime we think that children are at risk, whether it's any organization at all, and we need to protect them.
And I echo those comments as well.
It's nice to have some commonality around the table on this, because I do think that this is something, and I know as a parent to a young child, my little guy's still too little to be involved in any organized sport, but it's something that's actually very top of mind to me but what sport would I want to put him in? Because as much as my happy spot as a kid and my happy spot now as an adult is at the top of the slopes with skis strapped to me. That has always been my way of getting out and just kind of de-stressing and connecting back to nature. But there are so many allegations of abuse, and there's so many cases coming up about kids being abused by their coaches and sexually abused by their coaches. And I think that makes parents, at least it makes me, very nervous. What am I putting my child into? As much as I know there's tons of benefits, in the cases where there is abuse, I don't think there could be a single benefit. Can you guys perhaps touch on that a little bit?
I'm trying to think of what else to add, because I'm in agreement with you 100%. That's something we need to look at also for the impact of parents' mental health, right? And being able to think, if I were a parent, do I want to put them in a sport at all? Because there's so much risk, right? With hockey and with gymnastics and dance and ballet, right? So it's what is safe to put kids into these days? Right.
I guess that speaks to the gatekeeping of those associations as well.
Mm-hmm.
And how
could you repeat that with the mic on now?
Okay, that speaks to, I think, the gatekeeping of those associations and how we check to see the checks around who's who and who comes from where. And I think in all sports, in many educational institutions, that is something that falls short.
So is it troubling to you that the Government of Canada is still providing funding to many of these organizations in spite of?
It's not troubling to me. It's troubling to know that children are suffering as a result of that. And I think that's the inside work, perhaps, of those associations to look at. I think sports are generally good. I don't think all of the coaches are. If that were the case, then yes, I think the government should get in there. But I think that the associations need to take responsibility for those that they bring in to coach.
And to me, I find it exceptionally troubling that there have been allegations that these organizations are actually covering up some of the abuse, and so to me that is part and parcel of the issue.
Right. It speaks to the same thing that went on in the residential schools. It speaks to the same things that go on in educational schools for settler folks here in Canada as well, private schools or not, or public. There are always people that infiltrate. It speaks to families where there are abusers within the family. I think it's systemic. And I think it takes a lot of work and insight and working together as psychologists, psychotherapists, counselors, and so on to be able to help, and also for all the governments across Canada to be able to work in sync on that. And to put the information out, I would add, to the counselors and the therapists when they do print 140-page things, to make sure that we are getting access to that so that it's more publicly aware as to where funding's going, who's being funded and how we're getting access to the information. Is it a bottom-up or is it a top-down? I would hope it's a bottom-up.
Thank you, Ms. Foster.
Thank you.
The last round of questions for today's meeting will be posed by Mr. Joe Hardy, please.
Thank you, Mr. Chair. And look, it's a great opportunity for me to ask a second round of question. Question is going to go to Professor Afifi. My apology. In 2011, you co-authored a paper with, I believe, Professor McMillan, which identified protective factors that may affect a child's resilience. These factors were organized into individual, family, and community level protective categories. In your perspective, what are some of the most important protective factors that affects a child's resilience?
So that was a review paper that we did in 2011, and since then we've published many papers in the area. We focused on the children within their environments, and so because protective factors can come at many levels, we also focus on things that we can change. So what is something that we can change? So at the individual level, it's really important for children to feel like they can feel optimistic and in control and positive about their future, have a plan. So that's really important so that they can envision their life in 5 years instead of feeling like they're just have no control in their life. So that's very important. We also find that parenting relationships are very important. Telling your children that you love them, giving them hugs, spending quality time with them is very protective. Having an adult is very protective. So that can even be found in a school. It can be a teacher. It could be someone related, a positive person in sport. If they're providing that supportive, healthy relationship, then that is very resilient for those as well. Feeling safe in your neighborhood and environment is very important for resilience. And we're starting to look more at neighborhood and societal level factors that hasn't really been looked at yet. So we're trying to look at all of the factors in different levels so that we can understand the child within the entire context in which they belong and focus on protective factors at all of those levels.
Thank you. I saw a lot of nods from Mr. Girigades. Can you comment on that one as well?
Absolutely. I echo Professor Afifi's comments. The idea of taking an ecological approach to health and resiliency, not think about children as individuals that are isolated from family, community, peers, and the larger society, and thinking about them in a developmental way. That's why the importance of what we call longitudinal studies at the national level is becoming more and more important, especially in light of this pandemic. So taking an ecological and a developmental approach to understanding health and functioning as well as resilience and how that can be promoted, I think is very, very important.
Thank you. So you both talked about the emphasis on research and how research could guide us around some of the policies that we could develop, whether it's on regulation or whether it's policies, government policies, in providing a better access to governments, to the services. Can you talk about some of those policies and specifically federal government? How could we marry the research that you've done specifically around resiliency, specifically around protective categories into federal government policies? And you guys have, you both have about a minute and a half to go. Thank you. We start with you, Professor Afifi.
Oh, sorry. Thank you. So I think it's really important that we translate the data into policy and practice. And how do we do that? We do that with having open partnerships with the people that are going to use the data. So we develop the questions, the research questions at the very beginning with the people that are the community organizations, the decision makers, the policy makers, so that we're producing the questions that are relevant to those who need to use the data. When I started research, I just was the researcher. I did the work and I published it and I walked away. That's not my job anymore. My job is now to take the data and to put it into the hands of the people that can use the data and to make it come to life. We still don't have that connection very well between doing the research and translating the research into both policy and practice, so in clinical practice. And there's lots of mechanisms in place now where we can build those relationships so that we're all working together, producing the information that we need. So when you ask me, how do we know if kids are doing worse because of the COVID-19 pandemic? We know this because we have data, and the researchers are answering the questions that the policymakers and that the decision makers want to know, so that we can turn that data into policy and into practice.
Thank you, Mr. Chair. I know I'm over 5 minutes, but I appreciate feedback, if time allows, from Mr. Girgis as well.
Just very quickly, I echo Dr. Afifi's comments. I'm just going to say, I lived in Europe, I studied in the US, I live in Canada. I can tell you we have some of the best scientists, some of the best clinicians in the world. My hope, and I'm very encouraged by the meeting today, is that our representatives in all levels of government, especially the members of this committee, will continue to work together, take the information and the testimonies of all the experts and stakeholders and do something with it so that Canada can become the best country in the world to grow up as a child and become a useful citizen and a healthy citizen that contributes back to its community.
Well, Dr. Georgiadis, I'm really glad that we gave the extra 30 seconds that was an excellent note on which to finish. So thank you so much for that. Thank you to all of our witnesses for sharing your expertise and your experiences on the front line. They will be of significant value to the committee. There's a couple of administrative matters that I need to raise with committee members. So to our witnesses, you're welcome to stay, but you're free to leave, and we're very grateful to you for your attendance today. Two things to raise with you, three things actually. I know Mr. Van Koeverden has something. So first of all, we had yesterday referred to us another private member's bill, Bill C-293. So I know that our plan is to complete the work on this study before we consider whether we're going to private members' bills, but just so you know, now we have three that are waiting. The second thing is, during the meeting today, I received a notice from the whip that the Board of Internal Economy is going to be meeting on February the 16th, which will bump our committee out of its time slot. How that's going to be resolved is not yet determined, but I just wanted to let you know that there may be a problem with the February 16th meeting. We'll work on it between now and then, but that's just for awareness. And Mr. Van Koeverden, you had something.
Thank you very much, Mr. Chair, and I appreciate the indulgence. Two things very, very briefly. One, just a point of clarification for all members in this committee and anybody else. All federal funding for Gymnastics Canada and Hockey Canada has been frozen by the Minister of Sport in light of those allegations, and investigations are underway by the Office of the Sport Integrity Commissioner. But secondly, this was an observation I made earlier in the meeting. I feel that when we have hybrid meetings with witnesses both online and in person, the natural inclination for us as MPs is to focus on the people here in the room, which is normal, but I think it puts people online at a disadvantage. I would recommend that in the future, if possible, we can dedicate 1 hour to the people who are online and 1 hour to the people who are in the room, or only host meetings that are online or in person, because I think it was challenging sometimes to engage. I know that hybrid meetings have their advantages, but it's an observation that I just make today and pose to the committee.
Okay. We've opened the discussion. I can't very well terminate it without hearing from others that want to speak, but just be conscious of the time. So Mr. Garand and Ms. Goodrich, I think, want to speak on this point.
Actually, it was on another topic. It was not following up on what our friend Adam Koeverden said. The whip's office said there might be an opening for holding our meeting on Thursday night. Is that something that you've heard? Or
problems with that?
Okay.
I don't think we need to address them now. I'm aware of that suggestion, but in my case, it means I have two committees at the same time, and there are other people with issues there. So let's try to resolve this offline and then come back I think is best. I'd rather not get into a prolonged discussion on it now. Ms. Goodrich?
Thank you, Mr. Chair. I would suggest that if we have conversations around the formatting of meetings, it would be appropriate to have that in committee business, as is the typical practice of this committee and others. And with that, I move to adjourn.
Is it the will of the committee to adjourn the meeting? Yes. Thanks, everyone. We're adjourned.